So I could really talk about BCR all day long, and actually, we recently did that with a couple of others in this room at an NCI working group. It's a really fascinating space. It is not the same as other disease spaces. It has some really unique challenges. So I'm shamelessly stealing this figure from Dr. Handy Marshall, who's also in the audience. And the Hopkins group has really done a lot of work with sort of tracking the natural history of this disease. And of course, this shows two pathways, one in which a patient has a rising number for which intervention is started, ADT, and the other pathway where ADT is deferred until the occurrence of metastatic disease. And I want to say this doesn't just apply to prostate cancer. Increasingly, this is going to be something that all the diseases that are checking ctDNA, other serial biomarkers, MRD markers are going to deal with. And actually something that in the lymphoma world and others, you've already been dealing with in terms of how much do you treat these sort of slowly rising numbers. And this is a retrospective review, again, from the Hopkins group, looking at these so-called high-risk patients with PSA doubling times less than 10 months who are observed until developing metastases and then started on ADT. And the fascinating thing here is, when we're talking about quote-unquote high risk, we're talking about MFS on the order of 144 to 192 months, overall survival 168 to 204 months. Okay. And that includes the PSA doubling time less than 6 months. Okay. So we just have to really be careful about what we're labeling as quote unquote high risk. The other moving target, of course, is what are PSMA PET scans doing? And so this is a manuscript under review, but this is a patient of mine who comes to me with widespread PSMA avid disease, start hormone therapy, right? He's got double-digit PSA, but it's all sub-centimeter disease. Okay, this is disease that we wouldn't have known about previously. And with a PSA doubling time of about a year, we observe him for the next 2 years and do serial conventional imaging, and nothing happens. Okay, eventually, maybe a question of some bone disease. In retrospect, probably not even real. But Dr. Ravi Madden at NCI is actually doing a prospective study that looks at the natural history of PSMA-positive disease. So it's in this context that we have the EMBARK trial. And I won't go through all the details here, but essentially we're taking a patient population that maybe previously got X being ADT and then added enzalutamide at CRPC. And instead, we're turning that around and saying, does enza with or without ADT early matter? Of course, we're not testing this surveillance concept. And I think we're all familiar with these results by now, so I won't belabor them. I just wanted to point out that, in the enza-containing arms, there's about 20% dropout due to AEs. So I think that we're used to thinking of these conventional endpoints, PSA response, various time to event things. But I think that I wanted to point out that MFS is actually not validated here as a surrogate for OS. That's only been done in curative settings. So first of all, we can't assume that this translates into OS. We also need to contextualize that for a patient. So if you have pancreatic cancer and you have a recurrence, that's really bad, right? It's symptomatic, hard to treat. In prostate cancer world, usually these recurrences are asymptomatic. We have systemic therapies that are essentially 100% effective, at least at first. And so we have to ask ourselves, does a delay in a radiographic endpoint really matter? So I'd like to briefly introduce a concept called treatment-free survival, which is actually something that I've borrowed from my colleagues at BI and Dana-Farber Harvard Cancer Center. It's really been done, characterized mostly in melanoma and kidney cancer as a way of kind of capturing the longitudinal experience of a patient and sort of comparing trade-offs between the dual IO versus IO TKI approaches. So it's really actually capturing patients who are going on and off therapy throughout their disease course and living with or without toxicity, which of course can linger past treatment with those approaches. And so what that ends up looking like, it's actually derived from the Q-twist analysis from breast cancer world. And so you end up with these curves that sort of show patients moving through these different disease states over time, either dying of their disease or remaining alive, being on treatment or not, and being alive with or without toxicity. And so this is something that we put into a commentary about interpreting EMBARK, and I just want to take you through a slightly complicated figure here. But if I can turn over here. So in blue here, I have a patient who's on a surveillance strategy. So they've got BCR, their PSA is rising. We're waiting until metastases develop at this black arrow. And then we're starting this patient on ADT plus enzalutamide. They respond very well. They eventually become resistant, go on to get subsequent therapies, and then fortunately succumb to their disease. In contrast, we've got an EMBARK treated patient. So they're getting enzalutamide monotherapy in this example. And so for a rising PSA, they start enzalutamide. They have a treatment discontinuation as specified by protocol. Here I have them going on and off treatment because I think that's actually probably what most people will do, even though that's not what the trial did. And so as a result of that, this patient is becoming resistant and developing metastases at a much later point. So there's a difference in metastasis-free survival. Great, okay. But that's at the cost of more time spent on treatment. So the treatment-free survival are the sort of little blips here as opposed to the long arrow here. And of course, we don't know the answer to this question yet. And so we have to really think of this kind of concept when we're counseling a patient about whether or not you want to be on treatment and delaying that endpoint. Is that worth it to you? And I'll say when I talk about this with patients, I get very, very different answers from different people. Some people cannot sleep at night thinking about their rising PSA. That is a very important thing to be able to do something about. For other people, they say, well, I'm not feeling my disease. You're saying I could go years without anything happening. I could be wrestling with some fairly significant fatigue in, maybe 20, 25% of my patients on ENZA. Do I really want to do that? Many patients say no, or they actually do a trial of this and then say no. And so I think that in my mind, this is sort of a statistical way of capturing that, and something that for all the potential sponsors in the audience is something that we can actually build into prospective trials as an endpoint. And again, this is the kind of thing that in kidney cancer world helped us kind of salvage ipi-nivo for favorable risk patients, David McDermott's work. But I think it's got a role here in allowing us to intensify and de-intensify in this very complicated disease space, and not just try to go head to head along the more conventional endpoints.